Hi, and welcome to today's NephU podcast. I am Leah Beaird, Medical Science Liaison with Otsuka Medical Affairs, and I am joined today by Dr. Samuel Kantor, who is a nephrologist at the Nevada Kidney Disease and Hypertension Centers. Today we will be discussing the future of healthcare beyond 2020. Welcome, Dr. Kantor. Now, we are in the midst of a COVID-19 pandemic, and everything that we have known to be normal is not. And the way that we live, we work, we play, we go to school, and healthcare is with no exception. And so today we want to talk about how COVID-19 pandemic has affected your changes in your practice in your healthcare, and then thinking about beyond 2020, what will healthcare look like in that space as well. So Dr. Kantor, how has your practice changed over the last 6 months during this pandemic?
So Leia, back in March when the crisis began, our practice, obviously we're seeing patients in the office. And then suddenly, I guess it was about the second week of March, we closed our office because of the pandemic. And, we had to scramble because we had never done telemedicine before. And we were able to basically get up and running within about 7 days. And within the next week, we were doing pretty much all telemedicine. And now, what's happening is we're starting to phase in back to office visits, but we're still doing telemedicine. Probably right now we're doing about 2/3 telemedicine and about 1/3 in-office visits. Primarily the in-office visits will be for patients who have either an inability with technology to do smartphone conversations or computer conversations. And so they will basically have to come to the office to be seen because they have no other means. I think in the future, what will happen is, and this of course depends on the government because it has a lot to do with reimbursement. As long as the government is reimbursing for telemedicine, I think telemedicine is a good vehicle. We're seeing that now for patients that live far from the office setting, where they have to travel 60 to 80 miles to be seen. For those patients, it's certainly much easier to do a telemedicine visit. They're less likely to miss their visit because they're instantaneously transported to our office electronically. Mm-hmm. And I think it would be also helpful for people with comorbidities who are disabled, who have a lot of difficulty getting back and forth from home. They have to use wheelchairs, wheelchair vans, walkers, for those patients, it's certainly a lot easier to do telemedicine. People with difficulties breathing, they're on oxygen, it's certainly much easier to do telemedicine. I think the advent of telemedicine during the pandemic has made us realize that there's definitely a risk to have patients come to the office during a pandemic, a risk to them and a risk to the providers and their associates and their assistants within the office. Obviously, during a pandemic, people are infected, and you want to lessen the risk of transmitting infection. And I think telemedicine will do that for eternity. I mean, that's one of the benefits of it. So I think it might continue, but again, it really depends on the government. If the government supports it, then it will go on. I believe right now, the government has enabled telemedicine through October, and then beyond that, it's still up for grabs. We don't know. Right. But if it continues, I think a lot of offices will utilize telemedicine for the patients that I mentioned, or patients that have a great distance to travel where it's a big hardship.
Right. So you think then that moving forward, even post-vaccine, that we will still have telemedicine and virtual medicine for our patients?
I believe so. And I think, hanging your hat on a vaccine, you need to be very cautious. I always make people aware, if people are not aware, that influenza and influenza pneumonia have been around in this country for probably 100 years. And yes, we have a vaccine for influenza, and we give those inoculations to patients every year. And believe it or not, every year upwards of 60,000 Americans die of influenza and influenza-related infections. And you wonder, you say, wow, that's with the vaccine, 60,000 people die. And we know, like for instance, this year, that the influenza vaccine was only about 43% accurate. So they look for the isolates that they get throughout the world, and they try to build a vaccine based on the active isolates that are around the world. And this year it was only 43% accurate, which means a lot of people who get the vaccine might instead get the infection later on because they're not protected. And I think that whatever coronavirus vaccine becomes available, that it probably won't be much better than the influenza vaccine, which we perfected over the last few decades. And so there will be that risk. And of course, going forward, I think we realize from this pandemic that any disease, whether it be SARS or Ebola or influenza, or in this case, COVID-19, that as these infections occur throughout the world, they travel very rapidly and they spread very rapidly. And so we're going to have to be in a position to do this kind of pivot, if you will, from in-office visits to telemedicine as quickly as possible to slow the progression of the disease and to stop the infection spread. So I think telemedicine is here to stay. Again, it depends on the support of the government and whether they'll have an on-off switch based on pandemic conditions throughout the world, and they'll be able to turn it on and off as needed.
Right. I think that I agree that I've heard a lot of patients have enjoyed having telemedicine as well in all the instances that you mentioned, for those who just, it's difficult for them to get into the office. And I think that COVID-19 has catapulted the technology of nephrology in a very positive way. And so with that said, looking beyond 2020, what do you think will be the main driver for the future of healthcare?
So I think this pandemic has made us keenly aware of the need to be able to diagnose and to isolate different pathogens that are out there. And we need to react quickly to them, knowing that the spread can occur so rapidly. Things that occur 8,000 miles away from you can be in your backyard in a day or two. And so we used to look at things like Ebola and think that this is a remote disease in Africa and it will never reach America, and it did. And so we're going to have to be very, very keen on being able to diagnose these things quickly, learning about their spreads, and then be able to develop vaccines and treatments on a more rapid basis to save lives. I think that's number one. And I think number two is going to be studying the genetic consistencies of patients in order to determine who will respond well to a particular vaccine, who will respond well to a particular treatment, and how they will be affected by a particular pathogen. I think there's a lot of genetics involved. We're seeing that now with COVID, that it's unexplainable how a family can get infected with COVID simultaneously, and one patient will become acutely ill and and perhaps die on a ventilator, and the other 3 or 4 members of the family are completely asymptomatic. And you say, how is that possible? Now, they used to think that it was all comorbidities that had to do with, but I can tell you that I've seen patients die in the hospital now that are very young, who have no comorbidities. So there probably is some kind of a genetic composition or makeup of those patients that make them susceptible, but we can't isolate that yet. We don't have the technology. But when we're able to, I think that would assist us in determining who's going to do badly and who isn't. And that's very important for keeping people alive. Because I can tell you from just experiencing this pandemic that there are patients that go to the hospital that they're not acutely ill. They have maybe a fever and a little shortness of breath, and they're in the hospital for a week and they're convalescing, and then suddenly they get acutely ill, they go on a ventilator, and they're deceased in 3 days. And you say, wow, if I knew that was going to happen, maybe I would have done something differently. But we just don't know who those patients are. But they suddenly become acutely ill and die very rapidly. And if we had a way to diagnose that ahead of time, who is going to be susceptible, we would be, I guess, better at treating it or better at preventing a death. So I think that's the future.
That's great. Those are going to be great advancements for everybody concerned, I'm sure. So with all that said, then what is your biggest concern for the future of healthcare?
So I think my concerns that I see are we're in a very competitive healthcare environment. Everybody realizes the cost of healthcare. They're trying to contain the cost of healthcare. But at the same time, we need to do research and development. And where's that money coming from? Everybody seems to be cutting their research budgets because they're trying to provide drugs at a lower cost. But you can't do that. You can't sacrifice your research and development to do that, or we'll never have any of those progresses that we expect to have. And I think we have to come up with a method of funding or a manner that allows companies to still do research and make it economically viable for them to do it, because I think if we don't do it, we're in trouble. And I think government has not done as much research as they need to do because they're cutting their budgets too in order to save money. But we can't save a penny today and spend dollars later, because that's what's going to happen, because we're going to be chasing our tails trying to deal with the pandemics that we can't handle because we haven't done the research and development. So I think the funding of research and development for healthcare needs to continue, and we need to have a vehicle to do that and a manner to do that, whether it's tax incentives to companies or special budgets or other funding. We need to do it. We used to do it very nicely here in the US, but we've been moving away from that because, again, of cost cutting, trying to save money. But maybe that's not the correct place to save.
No, I think those are all great suggestions, and I hope that those that can fund can take that to heart and maybe go back to some of the methods that we used previously that did work. I think those are great ideas. One other question I have for you, kind of switching gears a little bit. NephU is one of the websites available that has resources for kidney disease, and I know that you have been on NephU, and this is where obviously this podcast will be housed. So how has NephU and PsycU helped you during this time of uncertainty?
So obviously when people hear PsycU, they say, well, I'm not a psychiatrist, why do I care? But I think what we're realizing is this pandemic has really surfaced or unsurfaced a lot of depression that's out there. A lot of my patients are alone, they're single or alone or widowed or widowers, and they don't have a companion, and now they're isolated from their family. Their family can't visit them because they're usually younger, and there's always a fear that they're going to spread the disease to their elders, and they just have nobody other than through electronic vehicles, which a lot of these patients are older and don't have that capability, the computer savvy or smartphone savvy to go online and meet with their families remotely. And so they're very alone. And I hear them telling me, especially the ones that come to the office, mention how depressed they really are because of the situation. And this is sort of the second victim, if you will, of these patients. It isn't just COVID, it's the depression and the isolation that occur because of the quarantine situation. So I think, your sites have done a very good job at making people aware that this exists, that this whole depression exists in COVID patients, or COVID and non-COVID patients alike. So that's very good. And I think, from a doctor's perspective, we definitely need a source of viable information. And where do we get that from? Well, sites like NephU and PsycU provide an insight into research that's going on in the fields. And I know through the COVID pandemic, NephU has, in fact, there's one on right now, I think, on the site, talking about the updates about what's happening with COVID-19 and what is new and exciting in the world of COVID-19. So it keeps us up to date and abreast of what's happening, because it's a very fluid environment today, and it's very hard to just get all this information and to distill it to a point of understanding. And I think your sites do that very nicely.
Great. I agree. That's good sources of information and up-to-date information for sure. So we have one last question for you. So again, thinking about healthcare beyond 2020, how do we continue to improve awareness and patient outcomes?
So obviously, we need to be in touch with our patients. And I think improving outcomes means you have to get people either into the office or through telemed. They need to make visits with their doctors. I think we learned acutely that during the pandemic, from March until May, a lot of offices didn't see patients and didn't switch to telemedicine right away. And those patients basically were uncovered, if you will. They had nobody following them for months. And now we're starting to see some of those patients back, and we're seeing that they had some serious comorbidities. There were issues going on that were missed because months went by, not under the care of a doctor. And we really need that follow-up care. I think it's very important that we have, at least established visits with patients, at least annually for some patients. Others maybe semi-annually, and others maybe quarterly, and some monthly or every 2 months, depending on their comorbidity situation. So I think that's important. And then patients need access to medication. I always bring this up when I do talks for pharmaceutical companies. And at the end, I talk about, well, now you know about the drug, but now the issue is you've got to get that drug into the patient's hands. So access is very important. And that's where pharma comes in, is the ability to educate patients through materials and also to provide programs, assistance programs, copay programs, and other methods to get the medication in the hands of the patients. Because, as good as a physician as I might be, without medications and without therapies, I can't impact the patient care as much as I could without those things. I'd have to have those things to do it. So.
Right. Well said, and thank you. And thank you so much, Dr. Kantor, for your insight and your experience and sharing this all with us today on NephU. So until next time, we'll see you later.
Thank you.